Hi guys, good morning.
Good morning.
Good morning, Professor Randall.
Hope everyone's well. I hope you had a good Halloween. You're staying warm. It's crazy windy out, but I believe the weather's actually supposed to get much better this weekend. So that's a cool thing. But anyway, we are halfway through the hip and the thigh. A few things I wanted to go over before getting into that. Man, I tried with the exam. I tried a whole new system with the self-recording and it blew up like a dumpster fire. So I'm sorry for everyone for having to go through the trouble of figuring out how to upload videos and totally, yeah, it was just a reckless mess. And I'm sorry for everyone the trouble you've had to go through for trying to upload videos, email them, so many issues. It was worth a shot, and we know it does not work. So for our next exam, which is going to be in a few weeks, we're just gonna have to do it good old regular fashion. You guys will take it while you are in your class time. So it is what it is, and then I can record you guys while you take it. It is what it is. I'm about halfway through grading. It's gonna take me a few more days. Got some other things to get under control first before I finish. So just be patient with me. And yeah, another thing is, if you guys ever, please never hesitate to ask questions. If you guys are very unsure of something I may have said in class, maybe an announcement, if you need some sort of clarification, or even just to kind of double check to make sure you heard it correctly, whatever it might be, please ask. Because last Thursday, last Thursday, there were students who were under the impression for my lab. I'm going to speak for my lab. Students were under the impression that there was no lab, but we did have lab last Thursday. I mentioned in lecture that we were going to have a shortened lab, and that was kind of it. But I never said that we were not going to have lab, and I'm nervous that some of my lab students missed some really important stuff. So if you are ever unsure of something, please ask. And yeah, that was kind of a big one, but I will always try and communicate with you guys as best as possible, as quickly as I can. You have to remember, I do have 1,000 other students and classes as well. So if I don't get back to you as promptly as possible, it's usually because either A, I'm doing something, I have work in another location, but I will respond usually eventually. If I don't after a few days, then totally follow up with me and be like, hey, Professor Arnold, I don't know if you saw my email or not. Absolutely okay. Um, Andrea, to everyone, said, speaking of videos, I tried to email it, but the file size is too big. Yeah, Andrea, a lot of people had that issue for sure. They had issues trying to upload it onto YouTube, which I found, I thought the YouTube thing was going to be successful because so many people had success with it before. I don't know. I thought YouTube, you were allowed to upload like a video that's as big or as long as possible. So that's kind of why it became an option, but I guess I was kind of wrong on that. So,
Oh my,
so bizarre.
it got cut like for half an hour.
Um, I don't know who's talking. I don't know if you are talking to me or if you meant to mute, but if you were talking to me, you can say it again, maybe a little louder.
With the whole YouTube thing, my video got cut like half an hour. So it only showed like 20 minutes of it.
That's so crazy. And Yuri, that's why you sent me two.
Yeah.
I'm sorry. It's so bizarre. Um, okay, everyone who's still struggling to send this, in the chat, just kind of mention, and I'll make a list during class of who still needs to get it to me, and I will figure something else out for you. But just type your name in the chat very simply, and I will make a list of the people who are still having problems, and I'll try and figure it out. Okay, but for now, while you guys are doing that, I'm going to set up the PowerPoint. Let's get through the rest of the hip and pelvis today, and we will go from there. In lab this week, you should be doing the knee. except if you have Professor Carver, you guys are a week behind. So she's doing the hip and pelvis. Everyone else should be doing the knee. Ray, you just popped in. I had everyone who was still having a hard time sending videos put their name in the chat, and I made like a quick list of that. So I don't know if you put if you put here for your attendance, or if you put here because you are also having a video issue. All right, so let's get started with our muscles today. Actually, but right before we begin the legitimate muscles for our lower extremity, I'm going to introduce to you the femoral triangle. So the femoral triangle is a section of the body that it's a triangle that is created through muscles and connective tissue. So you see we have our sartorius, adductor longus, and the inguinal ligament. So the inguinal ligament sits basically where your underwear, your bikini line kind of would sit along your body. And the inguinal ligament is the top of our triangle. So these three structures create the femoral triangle. Inside of this structure is where we have some really important lower extremity vein connective tissue pieces in there. So the femoral triangle has the femoral nerve. So the femoral nerve is one of the biggest nerves that runs through the anterior section of the body. We have our femoral artery. So this really thick red artery. The femoral artery is a branch off of our descending aorta. So it's a really, really thick artery. We use it a lot. I don't know if anyone's in acute care or in any of those emergency classes, but the femoral artery is a really important structure to know because we use that a lot when we have hip injuries. So if you have a patient who had a hip dislocation, femur fracture, trauma to the abdomen or the trunk, we use the femoral artery to take pulse since it's directly distal to that area. So the femoral artery is a really important one. Our femoral veins, so the great saphenous vein, and then we have lymph nodes. So all of these structures are inside of this triangle made up of these muscles and ligaments. Okay. They are all held within this pretty thin piece of connective tissue called the femoral sheath. Kind of keeps everything nicely in there and compact. Okay. And the acronym we use is NAVEL, NAVEL. So navel is located in the femoral triangle. You will see this in many things in the future, but definitely on a different quiz or an exam. It's just a really interesting little piece of anatomy. Okay. All right, moving on to our musculature of the lower extremity. So once again, I group these into pretty much anterior, lateral, medial, posterior muscles of the hip and the thigh. What we know about having these muscles on these parts of the body is going to be their fiber directions. So from our upper extremity, you guys should already have an idea if a muscle is located on the anterior side of the body, what types of motion do we think it's going to perform? And this is all going off of that angle of pull, the direction of those fibers. So anterior muscles, we're going to see.
When we see flexion.
Okay, great. Flexion. Excellent, Mercedes. What else?
Extension.
I think that was Yuri. Yeah, it was a little broken. Okay, so extension. Why would it not be extension? Let's think about this. Extension, we know, goes towards the posterior side of the body. So when the angle of pull on those muscles, it has to pull that body part behind us. Any of these structures, they're going to pull the body part anteriorly. So that's why flexion, we're going to see flexion most likely. I'll tell you what though, Yuri and Andrea, you guys said extension. There is one exception. The sole exception for this is at the knee. The knee is considered to be a backwards hinge joint. So we know our elbow is a hinge. We know the ankle is a hinge. The knee is also a hinge joint, but is a backwards hinge joint. So therefore, all of our anterior, posterior muscle principles kind of flip. So because at the knee, extension, the muscles that do extension at the knee are on the anterior side, and vice versa for flexion in the posterior side. So keep that in mind. But normally, probably 95% of the time, our anterior structures will do flexion, probably internal rotation, and adduction. Whereas our posterior structures will most likely do extension, external rotation, and abduction. We mainly see abduction on the lateral side of the body, but for instance, the gluteus maximus will kind of pull the hip into abduction as well. This was a wasted slide. I'm sorry. That should not be there. Okay, so we are going to begin with our anterior muscle groups. So the anterior muscles, again, flexors, horizontal flexors, internal rotators. Our first muscle that we are going to look at is called the iliopsoas muscle. So the iliopsoas is a combination of technically 3 different muscles. Some people will say it's only 2, but it's actually 3 different muscles. So we have, let's do my pen. We have our iliacus. We have psoas major, and we have psoas minor. So iliacus, psoas major, and psoas minor. The 3 of these combined, the 3 of them combined create the iliopsoas group. And these muscles are altogether known as the main hip flexor. So 1, 2, and 3 create the iliopsoas. They have 3 different organs, but they all insert at the same location, which is very helpful. So the origin for our iliopsoas is going to be the iliac fossa. So this is called the iliac fossa right here. We have, and then psoas major and psoas minor originate off of our lower thoracic and lumbar vertebrae. So iliac fossa and lower thoracic and lumbar vertebrae. They then all come down together and they all insert on the same location, which happens to be our lesser tubercle. So right here, we have the lesser tubercle. Okay. And the nerve for our iliopsoas is going to be that femoral nerve, which we just brought up before. Okay, so once again, we have 3 different muscles, 1, 2, and 3. And again, it creates the iliopsoas, iliacus, psoas major, and psoas minor.
What's the action?
Hip flexion. Hip flexion. This is our agonist hip flexor. Good question. I apologize. I don't know if I said that. All right. Any other questions on our hip flexor, iliopsoas? All right, excellent. Moving on to the beginning of our quadricep group. So the rectus femoris is 1 out of 4 muscles in the quadricep. The reason we are kind of isolating our rectus femoris muscle because it is the only quadricep muscle that crosses over at the hip and over the knee. It is the only one. What is a name for that when it crosses over 2 different joints? So it crosses at the hip and at the knee. Biarticulate. Very good, Mallory. The rectus femoris is a biarticulate muscle. So it crosses 1 and 2. So the origin for our rectus femoris is the AIIS. Someone tell me, what does that stand for? AIIS. Anyone remember this landmark? So the A, go ahead, Joanne. I don't know if you were going to say anything or not.
No, I just accidentally unmuted myself.
Okay, no problem. Okay, very good, guys. Courtney, Mallory, Alex, Tyler, excellent. Anterior inferior iliac spine, AIIS, anterior inferior iliac spine. ASIS is the anterior superior iliac spine. The rectus femoris is at the AIIS. And it comes down, crossing the hip. It is also probably the most superficial of our quadricep muscles. And all of the quad muscles kind of come together to create one tendon. And it inserts on the patella, but then the tendon kind of continues to run over the patella, and it will insert on the tibial tuberosity. Tibial tuberosity. So we have our quadricep tendon that inserts on the patella, and then coming off of the patella is that patellar tendon, which inserts on the tibial tuberosity. So the answer for insertion for any of our quadricep muscles would be the tibial tuberosity via the patellar tendon. So if we look at our rectus femoris, if we try and pull that insertion point to the origin, what actions do you guys think we're going to see at the, remember, we're going to see an action at the knee and at the hip. So if we try and bring that tibial tuberosity up towards the AIIS, what type of actions would we see at those joints? Anyone? Any guesses? Okay, hip flexion. Very good, Mallory. So we're going to see hip flexion, and we are going to see knee extension. Remember, the best advice I can give when we are pulling that insertion to the origin, picture trying to bring that tibial tuberosity up to directly following the fibers up to that AIIS. When we do that, we will extend the knee and we will flex the hip. Okay. So the actions for rectus femoris are hip flexion and knee extension. And this rectus femoris is also femoral nerve. All right, moving on to our vastus group. So these are the rest of our quadricep muscle. Remember, quadricep means 4. So we did 1. Now we have 2, 3, and 4. We have our vastus lateralis, vastus medialis, and vastus intermedius. The vastus intermedius is located directly underneath the rectus femoris. So it is deep to the rectus femoris. Okay. And they all, so keep in mind, these three muscles do not cross over the hip. They do not cross the hip. They only cross at the knee. So they have no action at the hip at all. They all insert on the tibial tuberosity via the patellar tendon. So all three of these insert on the tibial tuberosity via the patellar tendon. They do all have different origins though. So our vastus medius originates on the, we're going to keep this simple, the neck of the femur. So the origin for vastus medius is the neck of the femur. So right there. And then the insertion is that tibial tuberosity. The vastus intermedius, it originates on the anterior proximal femur. So anterior meaning the front, proximal meaning the top of the femur. Once again, comes down to insert on that tibial tuberosity. And then lastly, our vastus lateralis, the origin is that greater trochanter. And it's going to come down and insert on the tibial tuberosity. So who can tell me, why does this muscle need the patella in order for it to function properly? Who can explain that? Why do we need that patella in order for our quadricep to function properly? What is the point of the patella? It's a free floating bone. Why do we even have it? Okay, good, Tyler. More torque. Yes, very good, Alex. It is increasing our leverage. So the patella, by having this massive, well, considered to be massive structure over this flat area, the patella is going to create way more leverage, which is in turn going to create more torque. It is increasing that force arm, which we know is going to increase the amount of force and power that is produced at the quadricep. So we need that patella there in order for us to get more power from the quadriceps. Excellent, guys. We're going to talk about Q angle very briefly. So our Q angle is going to have a lot to do with this as well. Q angle stands for our quadricep angle. So if we are to measure from, I believe it's ASIS, our ASIS down to the center of our patella. And then keep in mind, this would be a straight line. And then from the center of the patella to our tibial tuberosity, the angle that is created right here is called the Q angle, the quadricep angle. And what that is going to tell us is how much of an angle is our quadricep muscle on when it is pulling at the patella and the tibia. Females naturally have a greater Q angle as opposed to males. Why? Why is that? Why do females have a larger angle compared to males? Excellent. Wider pelvis, and that's usually for birthing. Females have a naturally wider pelvis. So I'm going to change the color of this to make it a little bit easier to see. And I'll probably go back. So females have a wider pelvis, which means that their ASIS is going to be further out. So say that's where a female's ASIS is. If we take this angle compared to, say, a male's, which would be right here, and then this comes down to the tibial tuberosity, the female angle is going to be significantly wider as opposed to the male's, which is almost non-existent. So females have a greater Q angle because of those wide hips. Q angle, we're only going to kind of talk about that. This Q angle is also a big predisposing factor to ACL tears or any type of knee injury. And that's because our quadricep, again, these structures are pulling on the tibia. If the Q angle is greater, it's pulling on the tibia and the patella more than it needs to. Whereas males, the fibers basically run almost directly up and down, where females, the fibers kind of go off on an angle. So it's going to pull that patella and the tibia on an angle as well, leaving you with a predisposing factor for ACL injuries. Okay. Does that make sense to everyone? Q angle. Okay. You guys are going to cover that more as well in like your lower extremity classes, but thought this was a good place to kind of introduce it to you. Any questions on our quadricep muscles? I did not give you the nerve. So for our vastus group, all three of our vastus muscles are also femoral nerve. Any questions? Okay, cool. We are going to further move on to, and also I wanted to mention in lab this week, we are going to further go over that patella. We're going to look at further the patella along with the Q angle. So you guys will see that again in lab. All right. One of my favorite muscles in the body is going to be our sartorius muscle. So the sartorius is known to be the longest muscle in the body. Oh, sorry, Nicole. So the action for the vastus group is all knee extension. That's it. Remember, they do not cross over the hip. They only cross over the knee. And because of, so if they insert on that tibial tuberosity, they pull straight up the thigh and the femur, it's going to be knee extension. All right, moving on again to our sartorius, longest muscle in the body. It goes all the way from our ASIS down to our pes anserine. So the pes anserine is this flat section of the medial tibia And the term pes anserine actually means goosefoot. So pes anserine means goosefoot. And this location is where our sergeant muscles are located. So SGT. And the sergeant muscles insert on the pes anserine. Our sartorius. Our sartorius is the first sergeant muscle we are going to look at. So that is the S. So the S in sergeant is sartorius. So the sartorius, as we see, it crosses over the hip and it crosses over the knee. So this is another biarticulate muscle. This long muscle has a lot of actions. And that's because of not only the length, but kind of the angle at which it is crossing over these joints. So it's going to allow for a lot of actions at the hip and one action at the knee. So again, insertion, the origin is that ASIS and the insertion is that pes anserine. The sartorius is going to perform hip flexion, abduction, and external rotation. So flexion, abduction, external rotation. And at the knee, someone take a guess. What action do we think the sartorius is going to perform on the knee? It inserts at this pes anserine, and it's going to pull that pes anserine insertion kind of that way up. This one's a little tricky. So it's actually going to pull the knee into very slight flexion. It's a weak knee flexor, but I want you to kind of take note of the direction of these fibers. So it's coming from the medial tibia, and it's going up kind of around the femoral condyles and then going up and over. So it's going to pull that tibia kind of backwards very slightly. It's not a strong knee flexor at all, but it's still considered to do knee flexion. And the sartorius is also has the femoral nerve. Any questions on our sartorius? We good? Okay, do you guys have any questions on the sergeant muscles? So our SGT, our sergeant muscles, that is an important group to know. Our sergeant muscles are the three muscles that insert on the pes anserine, and we're going to see the other two through the rest of this PowerPoint. Okay, we are moving on to our posterior muscle group. So the posterior muscle group we know is predominantly performing hip extension, hip abduction or horizontal extension. That's a terrible term. I need to get rid of that. And external rotation. And that includes our gluteus maximus and our hamstring muscles. So our first muscle is going to be that glute maximus, which is a massive, very massive hip muscle. And if you notice, the very large muscles that we've talked about so far in the body, such as our pectoralis muscle, the lats, they all have this really wide origin, and they come down and form one tendon to insert on. Those muscles, as we've talked about before, are considered to be super powerful. They produce a lot of force. They're just really not creating a lot of range of motion. So the origin for our glute maximus is going to be the posterior iliac crest, the sacrum, and the coccyx. So I'm going to keep those really simple for you guys. We have the posterior iliac crest, the sacrum, and the coccyx. And then these fibers come all the way across the posterior side, and they insert on the gluteal line, or it's also called the gluteal tuberosity, on the femur. So this is on the lateral femur right here. Here's our greater trochanter, and that gluteal line is basically almost directly inferior to that greater trochanter. To kind of help gluteal line, gluteus maximus. So same name, should help you kind of keep those straight. So glute max, once again, super powerful, has a lot of influence on the hip. And let's take that lateral femur right here where that gluteal line is. And if we're going to pull that back towards our origins, we are going to see hip extension, external rotation, and abduction. So hip extension, that's probably the main action of the glute maximus, is hip extension. It also does external rotation and abduction. Kind of an interesting thing to look at. If you were to stand up, any of you right now, if you were to stand up and try and bring your leg into extension, kind of take a look at how much extension you get. It's really not a lot. We don't have a lot of hip extension. But if you do the opposite and bring your hip into flexion, you're going to see we have a lot of hip flexion. That's due to the shape and size of these muscles. So glute maximus, again, it's a very wide and it's a very powerful muscle, but it's not creating a lot of range of motion because the muscle fibers are kind of shorter. Whereas if we look at our sartorius and our vastus group, and even some of these muscles, our iliopsoas, the fibers are way longer. So that is why rectus femoris, and that is why we are able to create way more motion with hip flexion. Does that kind of make sense to everyone? How our fiber shape influences our force production versus our range of motion. Okay, good. Awesome. Excellent. So that is our gluteus maximus. We're also going to briefly talk about the glute max when we get to our lateral muscles, but it's mainly, as you can see, it's mainly posterior. It's kind of, it only is considered lateral because of its location of insertion. And our glute maximus nerve is called the inferior gluteal nerve. All right. Moving on to our our hamstring group. So the nice thing about our hamstrings is they all originate on the ischial tuberosity, each one of them. So there are 3 hamstring muscles, and the main 3 hamstring muscles all originate on the ischial tuberosity. So it's a really wide, flat piece of bone here on the ischium, which allows for that muscle attachment. Okay, so sorry, give me 1 second, guys. Professor Carver is trying to call me, but I'm gonna ignore. Okay, so hamstring. This is the first one we're going to look at is our semitendinosus muscle. So the one thing I want to note about the semitendinosus is going to be the T. So this T in tendinosus is also the T in our sergeant muscle group. So the semitendinosus, it sits in the middle. So the muscle belly sits in the middle of the other 2 hamstrings. So we have one hamstring muscle and we have another. So the semitendinosus is in the middle. And so it originates on that ischial tuberosity and it comes down to insert. Where did we say our I almost gave away. Our sergeant muscles insert at? What is that location called?
Pes anserine.
Pes anserine, excellent. So the sergeant muscle, the T, is our semitendinosus, and the insertion is on that pes anserine, which is the anterior medial condyle. Okay, so that is our semitendinosus. All of our hamstring muscles, all 3, perform hip extension and knee flexion. Hip extension and knee flexion. Okay. So pes anserine, and our semitendinosus nerve is actually going to be our sciatic nerve. So you'll see in the chat, I put sciatic nerve tibial division. What that means is the sciatic nerve does not exactly innervate any direct muscle. It does have a ton of divisions. So it is technically the tibial division of the sciatic nerve. Okay, our next hamstring muscle is the semimembranosus. A nice little tip for the semimembranosus is we have 1M, 2M, 3M. The semimembranosus is the most medial of our hamstring muscles. So membranosus, we have the M's, M in medial. And again, it originates off of that ischial tuberosity, and it's going to come down to insert on the posterior medial tibial condyle. It's kind of a mouthful. So we're on the posterior side of the tibia, and it's that medial condyle right here. And our semimembranosus, once again, also does hip extension and knee flexion. Kind of the nice thing with the hamstrings, they all do the same action. They all originate in the same location. And our semimembranosus, same nerve. Sciatic nerve, tibial division. All right, and our last hamstring muscle is that biceps femoris. You guys have probably heard this before. Biceps femoris is the most lateral of our hamstring muscles. So the first two came around to insert on the medial side. Our biceps femoris actually comes down to insert on the lateral side of the leg. The origin, so biceps means two heads, bi meaning two, seps meaning heads, just like our biceps brachii. And so we have a long head and a short head. The long head of our biceps originates on that ischial tuberosity. So that same location we've been mentioning before. The short head originates on the posterior femur. We're going to keep that really simple. And then both of these muscles, so the long head and the short head, merge together and they insert on the fibular head. So origin, ischial tuberosity, posterior femur, and insertion is on the fibular head. And again, it's the same action, hip extension and knee flexion. Something really fascinating about this fibular head insertion. So we have a nerve. So the nerve that innervates our biceps femoris is called the common peroneal nerve, which is a branch of the sciatic nerve. So biceps femoris. And the common peroneal nerve, the way that it branches off of the sciatic nerve, it actually comes down, and I don't know why no one knows why it does this or why it was made this way, but the common peroneal nerve comes down and it actually circles. It kind of loops around the fibular head. So the nerve structure, again, comes down and it circles around the bone, the fibular head bone and the muscle. So if you ever have an athlete who is experiencing pretty severe nerve pain, maybe shooting down the fibula or directly over that insertion site, consider some things about the muscle. Maybe the muscle is really tight and it's impinging on the nerve. Or if you ever have an athlete get hit in that area, remember, it's not just a muscle insertion site, but it has this nerve circling around it. So that's the common perineal nerve. Okay, any questions on our hamstrings? Excellent. Moving on to our lateral muscle group. So the lateral muscle group is going to be the rest of our glute muscles and the TFL. We are not going to go over the sartorius again. The only reason sartorius is also kind of considered part of the lateral group is because of its origin at the ASIS, which is considered to be kind of lateral, but we're really not going to talk about it again. So our glute medius, the glute medius muscle, so here we have, it's in the middle of glute minimus and glute maximus. So our glute max is the most superficial of these muscles. Glute maximus kind of comes all the way down like that, even a little bit probably further up. And glute minimus is located deep in here. So medius is directly in the middle. Our glute medius muscle plays an extremely important role in supporting our pelvis and supporting our hip and our core. So when we have a weak or an injured gluteus medius muscle, that is where we see a lot of postural and gait issues in the body. So posture meaning when we are standing, gait when we are walking and running. So the glute medius, the origin is going to be the posterior iliac crest. And the insertion is the greater trochanter. So origin, posterior, right underneath that iliac crest. And insertion is that greater trochanter. And glute medius performs abduction of the hip. So hip abduction. And our nerve for our glute medius is actually the superior gluteal nerve. Glute maximus was that inferior gluteal nerve. Glute medius is the superior. Okay, once again, we have lastly the gluteus minimus, and our glute minimus muscle is the deepest of the gluteal. So it's deep within that pelvis. Very, very simple muscle. Origin is going to be that posterior ilium. So posterior ilium. And insertion is also going to be the greater trochanter. And if we are pulling that insertion, so if we're trying to bring that greater trochanter up towards that posterior ilium, it's going to perform hip abduction. And this muscle is also the superior gluteal. Okay, any questions on our glute muscles? Glute maximus, minimus, medius. I want you guys to know which of these muscles is considered to be the most superficial, which is considered to be deep. Okay, we know glute maximus is the most superficial for sure. All right, moving on to our final lateral muscle is called the tensor fascia latae. I don't know why I love the name of this muscle. It's kind of cool. The TFL, aka the tensor fascia latae. And this is a very interesting muscle because it has the longest tendon in the body. Earlier, we mentioned the longest muscle in the body. Who remembers what is the longest muscle?
The sartorius.
The sartorius. Excellent, Annalise. The sartorius. And our TFL has the longest tendon. So the muscle belly for the TFL is right here. And then this is all tendon, which is kind of crazy to think about. So the origin for our tensor fascia latae muscle is the iliac crest. So it's kind of the anterior iliac crest, and it's along a little bit of that lateral side as well. So we have some fibers that kind of come up anteriorly and some fibers that come up laterally. So we have some this way and some. And so again, that muscle belly stops right here and it turns into this really long tendon. This is called your iliotibial tendon, your IT band. Sure, you guys have heard of your IT band before, but this is what it is, your IT band. And it's iliotibial. It goes all the way from the ilium all the way down to this lateral condyle of the tibia. Does anyone remember this landmark located, this flat landmark located on the lateral proximal tibia? So here's our tibial tuberosity right here. We have our pes anserine right here. Anyone remember this landmark location? So this is called Gerdy's tubercle. Gerdy's tubercle is located on the lateral proximal tibia right there. Pretty easy to palpate on yourselves. That's something we can kind of do when we're back in person together, kind of help you guys find those palpation locations, especially when you get into lower, which I think is next semester. But again, Gerdy's tubercle is the insertion location. The IT band also inserts on our patella and a little bit on the fibular head. So it branches off to slightly attach to the patella and also slightly attach to that fibular head. So 1, 2, 3. The action for the TFL and IT band is hip abduction and very, very, very weak hip flexion. So it does a very little bit of hip flexion as well. And the nerve for our TFL and IT band is the superior gluteal nerve. Any question on our insertions or anything about the TFL and our IT band? All right, excellent. I'm gonna keep on going, almost there. Our last set of muscles are going to be our the medial group. So these are the adductor muscles. Before we kind of get rolling on to the specifics, I want you guys to know I'm going to put an S and a D next to these muscles, and it's going to represent which are considered to be superficial, which are considered to be deep. So our pectineus is a superficial adductor. Adductor magnus is deep. Adductor longus is superficial. Brevis is deep. And gracilis is superficial. I apologize. I should have grouped them better on the slide itself. I just didn't really think about it till this second. And in order for us to be able to really palpate adductor magnus or adductor brevis, they're really deep within pectineus and adductor longus. The gracilis is so thin, it doesn't really impede with our palpation. But just know that magnus and brevis are deep to the rest of these three. So the first adductor is going to be our pectineus muscle. Very short. It is a very, very short muscle. It honestly works better as stabilizing our entire hip. So the origin for our pectineus is going to be on the pubic bone. Okay, so the pubic bone and the insertion, I'm going to keep it simple, is going to be the proximal medial femur. So the proximal medial femur. And the action for our pectineus is going to be hip adduction and hip internal rotation. So it's going to pull our hip in and internally rotate that femoral head. Excuse me. And the nerve, I think for almost all of our adductor muscles, pectineus is actually, I'm pretty sure, is also our femoral nerve. Pectineus is also the femoral nerve. Okay, adductor magnus. As you can see, adductor magnus is massive. This is our strongest adductor muscle. So adductor magnus is very, very, very large, and it's very, very powerful. The insertion goes along our entire ischium almost along the entire ischium and part of the pubic tubercle. So the origin is along the ischium and the pubic tubercle. It's also going to be coming down the entire length of that linea aspera. So the linea aspera is on the posterior femur, and the adductor magnus inserts along that entire linea aspera all the way to the adductor tubercle. So insertion is linea aspera and adductor tubercle. And adductor magnus is going to perform, again, hip adduction. Adduction. It doesn't have enough angular torque to perform internal rotation. We're going to kind of leave that up to the rest of our adductor muscles. And the nerve for adductor magnus is going to be our obturator nerve. And the obturator nerve comes through the obturator foramen, which is right here. And it's going to innervate most of our adductor muscles. So adductor magnus is innervated by the obturator nerve. Anyone who needs to leave for class, go for it. I'm going to kind of keep going and finish up these last few muscles. Okay. So if you have to go, that's totally fine. If you wish to stay on, that's okay too. So adductor longus is once again a superficial adductor muscle. And the origin is going to be that pubic tubercle. And it's going to come down to insert just on middle posterior femur, which is that linea aspera. So middle posterior femur. And adductor longus is going to perform hip adduction and very minimal internal rotation. Adductor longus is the obturator nerve. Okay, almost there, I promise. Adductor brevis is a shortened adductor muscle. So if you look kind of back, adductor longus is right here, and adductor brevis kind of fits in directly above it, right there. So adductor brevis origin is going to be that pubic tubercle. And once again, insertion is almost super similar to that adductor longus. It's going to be the posterior middle femur where that linea aspera is located. So magnus, when we talked about adductor magnus, it basically covered the entire length of the linea aspera, whereas brevis and longus were only portions of it. Adductor brevis is going to do hip adduction and internal rotation. And adductor brevis is also going to be that obturator nerve. Okay. And then the last adductor muscle for the medial group is the gracilis. So gracilis is super interesting. It's a very thin muscle. And when we pull our groin, we are normally referring to either the pectineus, or if we strain an adductor, it's usually going to be that gracilis or pectineus. Gracilis also crosses the knee. However, it really does not create any action at the knee because of this line of pull. So if we look, these muscle fibers are just going straight back up like this. The tibia is not able to move laterally. It's a hinge joint, so it only really can perform flexion and extension and very little bit of tibial rotation, which we're not going to talk about today. So it's really, the only action it definitely does at the knee is stabilize. So it kind of acts as a knee stabilizer right here. The origin for our gracilis is going to be that pubic tubercle. And the insertion is that good old pes anserine. So what does that mean about the gracilis? It means that it is our final sergeant muscle. So the gracilis is the G in our sergeant muscle group. So sartorius, gracilis, semitendinosus create the sergeant muscle group that inserts at the pes anserine. And the action for the gracilis is going to be hip adduction. Our nerve is going to be the obturator. Okay, our final group, you guys do not need to know origins for these muscles. So these 6 muscles here are called the deep 6 rotators. They all lay on top of each other. They're kind of spanned out a little more. This picture doesn't really do them justice, but they're kind of spanned out. And they all insert on the greater trochanter. So we have our piriformis, which is the top and the biggest of our 6 rotators. We then have our gemellus superior, gemellus inferior, obturator externus, obturator internus, and our quadratus femoris. Really, the only one of these that I want you guys to kind of know is going to be our piriformis muscle. So here we have our piriformis. And it, again, it inserts on the greater trochanter with the rest of our deep 6. It also performs external rotation like the rest of these. So our deep 6 rotators are located on the posterior, deep posterior side of the pelvis. So when they pull that greater trochanter, they're pulling the whole femur back into external rotation like this. The piriformis is going to be significant because its location, the sciatic nerve comes off of our spinal cord and it's going to run directly through the inside of our piriformis. You guys may have heard of piriformis syndrome before, or you've heard of sciatic nerve pain, sciatica. That is normally due to that piriformis muscle tightening up around that sciatic nerve. So the sciatic nerve is super thick, like that, and it runs directly through that piriformis. So that one muscle, that one little tiny muscle, can cause so much pain in the body, and it shoots pain down that posterior lateral side of the leg. Okay, so that is our deep 6 rotators. They perform external rotation. They insert on the greater trochanter. Do not worry about the organs. I think that's just too much to ask for all of these. And our nerve, so the piriformis nerve is the anterior rami nerve. The other 5, so gemellus superior, inferior obturator, externus internus, and quadratus femoris, they all are innervated by the obturator. So that is our deep 6 rotators performing hip external rotation. And the rest of these are movements. The ligaments we will briefly cover. Actually, I can cover these very, very quickly, but I'll go over them again on Thursday very quickly as well. Again, no one is forced to stay. If you wish to stay, that's fine. So for our ligaments, we have 3 main ligaments. The Y ligament of Bigelow. This is our iliofemoral ligament. If you remember, ligaments attach bone to bone. So iliofemoral goes from the ilium to the femur. Ilium to the femur. And the purpose of our iliofemoral ligament is to prevent excess motion. So it's going to limit hyperextension at the hip. On this medial band here, it's going to limit external rotation. So if you try and externally rotate the hip, it's going to stop at a certain point, and it's because of this. I'll highlight it quickly. It's because of this particular band, the medial band. Right here. And then our lateral ligament here prevents any excess adduction. So as a whole, this entire ligament, the Y ligament, it not only reinforces the capsule, but it limits hyperextension, it limits external rotation, and it limits adduction. If you can picture in your head the femur going into these 3 motions, you can also picture this ligament being put on a stretch, because it is. It's being stretched and it's trying to limit that excess action. Next ligament is the pubofemoral. So it runs, the pubofemoral is this green ligament under here, and it runs from the pubis to the femur. And the pubofemoral ligament helps limit abduction. So if we try and take that femur and abduct it as far as it can go, we're gonna feel that pull stopping it, and that's due to the pubofemoral ligament pulling it back the opposite way. Lastly, we have, the ischiofemoral. So our ischiofemoral ligament goes from our ischium to the femur. As you can tell, it's a very big and wide ligament. And that ischiofemoral prevents excess internal rotation. So it prevents any excess internal rotation. The ligament's going to pull the femur back towards external rotation very slightly. And our final, ligamentum teres. I kind of mentioned this last week when we were going over the basic anatomy. So ligamentum teres is a tiny ligament right here, and it comes out of the fovea capitis. The fovea capitis is that tiny, tiny hole located in the head of the femur, and it will come and attach to the acetabulum. So this little ligament basically is a large portion responsible for keeping the femur attached to the socket. In the fovea capitis, we have not just the ligamentum teres, but we also have nerves and arteries running through the fovea capitis that feed and give nutrients to the rest of the femur. So when we dislocate our hip, there's a really good chance, or if we tear this tissue, there's a very good chance that we are bleeding out and we are not allowing nutrients to get to the femur. So that's considered to be a medical emergency. So call 911 if there's a hip dislocation. It's also extremely painful. Final ligament is our inguinal. This is the top of that femoral triangle, as I mentioned to you guys earlier. So that inguinal ligament goes from our ASIS all the way to that pubic tubercle. This is an important structure because when we have hernias, sports hernias are very common. Hernias is when a part of the tissue, such as the muscle, kind of pokes through the ligament, or the ligament itself will poke through the fascia of this area. So we also have certain muscles that attach to this ligament as well. So some of our abdominals are an example. Okay, sorry guys for holding you. Great job today. We are done. We are through. But I will post that onto D2L for you, and I will see y'all on Thursday. So great job today. Take care.
Thank you. Have a good day.
Around, guys. Bye.
I have a quick question.
Sure, Angeles.
Is this PowerPoint on D2L?
Yes.
Okay. Thank
Is
you.
it not?
I don't see it online.
Should be.
The last
Oh my gosh.
I see is wrist and hand.
That's so crazy. Well, it should be now. I don't know why I did that. I'm sorry.
It's okay.
Thanks for letting me know. I would have realized eventually, but not soon enough.
Okay, thank you.
You got it. Bye.